This brings us to the second part of the talk, which is about the clinical interest of this technology. And as said, after an acute brain injury, patients may evolve to coma, where some will go to irreversible coma, meaning they will never recover and lose all brainstem reflexes. And this was an entity defined in the 50s when we had a new machine, the artificial respirator, which kind of obliged medicine to redefine death based not on cardiorespiratory criteria, but based on neurological or brain criteria. In the 60s, Fred Plum and Posner in New York defined a very rare but not to miss entity of pseudocoma or locked-in syndrome. Patients survive their coma, fully conscious but unable to move, only can communicate through small eye movements, locked-in syndrome. In the 70s, Brian Jeanette and Fred Plum defined the vegetative state, patients who awaken and move, but all movements are reflexes, no signs of awareness, and this is called the vegetative state in the 70s. In 1994, the Multi-Society Task Force in the States defined the temporal dynamics of this. Looking at all published cases, they could define that there is something like permanent vegetative state, meaning no chances of recovery, for 1 year after a traumatic brain injury and 3 months after non-traumatic, mainly anoxic brain damage. As said, in 2002, the Aspen work group defined the minimally conscious state. Here patients show more than just the reflex movements we see in the vegetative state, but nevertheless cannot communicate. So minimally conscious state patients might, for example, smile to their mother, and only if it's their mother in the room. Or they will orient towards noxious stimulation. Or they will even show command following. They will squeeze your hand when you ask for it 2 times out of 4, but not in a way that you can use it for a yes-no coded communication. And at present, we do not know if there is something like permanent minimally conscious state. All we know is that outcome is better for minimally conscious as compared to vegetative, but we do not know when there is no longer any hope for recovery in patients with this very challenging condition, which is called minimally conscious state, which can, as the vegetative state, be a transition to recovery of consciousness or can remain chronic. So, the first, like always in medicine, is the correct diagnosis. And I think it all comes down, when trying to say meaningful things about human consciousness, we're trying to say something about conscious cognition, but all we can do in these coma survivors who cannot communicate is look at their motor responsiveness. So, as we said, as soon as a coma patient recovers arousal, meaning eye opening, but only shows reflex motor behavior, it is called vegetative state. The next boundary will be very important, will be as soon as we have more than reflex, meaning voluntary behavior or command following, which will be the boundary defining minimally conscious state, and there the upper boundary, which is again very important. After asking, is the patient conscious, then it is, what is that consciousness like, and that needs communication, and that is the upper boundary of minimally conscious state. And I think a good example of how difficult it is to find those small signs of consciousness is, I think, a widely discussed patient in the media. We saw him now 4 years ago, and with his family, with his mother, who told us he has the diagnosis of vegetative state for over 20 years. And by bedside clinical examination using a standardized scale, which is the coma recovery scale, we could identify small but real signs of consciousness, despite the fact that clinically we had no way to communicate with him. So the first question, as always, we ask in these patients is the patient conscious? In this case, the answer was yes. And it was a difficult question, illustrated by the fact that for many, many years, those small and fluctuating signs of consciousness have seemingly been missed. The next question is, what is that consciousness like? And that needs communication. And here, and that's the part actually that the media really zoomed into, is something we have nothing to do with, and that is the family afterwards finding what is called facilitated communication. So despite the fact that we never proposed it, neither in this case or in any other case, they thought they could communicate with the patient by this technique, which basically means that somebody holds the patient's hands and then using a keyboard or a computer gets to a communication. Now, this technique has a bad reputation in children with severe developmental disabilities, profound mental retardation or autism. We know that most, if not all, of the studies have shown this technique not to be valid. But to our surprise, and despite the fact that it is not so much in Belgium, but more so in Germany, the UK, and the States, used in traumatic brain injury, there isn't any scientific study on its validity. So with Marie-Aurélie Bruno from our group, we looked at the validity of facilitated communication, and the conclusion is that she couldn't find any patient where the communication using facilitated communication in traumatic brain injury patients showing no other way to communicate was valid. So I think it's very important to disentangle those two important questions. Is the patient conscious? In this case, clearly yes. And then, can the patient communicate? Well, in this case, I think facilitated communication is not something we will propose to our patients. We will look for alternatives, as I'll come back to in the rest of the talk. So that patient was one of those who made us realize how difficult it can be. And so we left the anecdotal and tried to bring it into the scientific evidence, where we looked, and this is a study published by Caroline Schnackers last year in BMC Neurology, over 100 post-coma patients, where we asked about the clinical consensus diagnosis. And when you compare the diagnosis vegetative state with the diagnosis you obtain using a standardized and validated consciousness scale, in this instance the Coma recovery scale revised, we saw that out of the 45 patients, 18 actually were not vegetative. So this brings us to a potential misdiagnosis of up to 40% of the cases. Of course, this is unacceptable, and in the paper we not only document the rate of misdiagnosis and actually only confirm previous studies done in London by Keith Andrews, later Nancy Childs in Texas, but also propose a solution to the problem, which is just paper and pencil. It's a standardized way to systematically look for small signs of consciousness, and I think that the Coma recovery scale, which we validated also in French, in Dutch, there's many languages where you can find on the website comascience.org the manual. There's also now a video. If you are interested, you can send us an email and we will send you how to use this scale, because I think this can really change and improve our bedside assessment. And now also the Belgian Ministry of Health, after this study came out, obliged all the expert centers to use this scale before making the diagnosis of vegetative state. Eye tracking is often one of the first signs of consciousness we see appearing when patients transit from vegetative to minimally conscious state. Myself, for example, at medical school, was instructed to just move my hand and see if the patient shows visual pursuit. This study by Audrey van Oudenhuizen from our team shows we maybe should be using a mirror. And what we see here is that compared to a mirror, a moving person and a moving object, we see that there are patients who only show eye tracking to a moving mirror and not moving person or moving object. So if this is true, we should, when we look at these patients at intensive care, be using a mirror before we assess and conclude that there is no sign of eye tracking, and hence may potentially miss patients with this first sign of consciousness. So the own face obviously is an autoreferential attention-grabbing stimulus, so is the patient's own name. So this, now in the auditory domain, was also a stimulus we've been using when we were recording the electrical activity of the brain, looking at evoked related potentials, the brain's response to the own name. What you see here is that when you present the own name compared to a series of unfamiliar names, the brain does something different. There is a P3 response here, colored in pink. We can clearly measure also in locked-in syndrome patients and in patients with a minimally conscious state, but also, and to our surprise, in patients who were in a well-documented vegetative state and remained without any sign of consciousness for more than a year. So in other words, the P3 response to the own name, again an attention-grabbing stimulus, is, in our view, not a necessary sign of conscious perception of the stimulus. So we needed to, again, improve our paradigms. Also, using functional neuroimaging, we know that emotionally and autoreferential meaningful stimuli are important. So this is a study where we looked in minimally conscious state patients to the brain activity in response here to meaningless noise. You see very little neuronal activity. Baby cries, emotionally arousing, recruit much more neuronal activity. And finally, the patient's own name, again, induces the most widespread activity, including here precuneal and anterior cingulate mesiofrontal areas we know are important for self-processing. However, here we also hit the limitation of technology. For how sure can we be that this, for example, precuneal activity truly reflects conscious perception of the patient's own name? Well, I think in the absence of a complete understanding of the neural correlates of consciousness, we cannot make such strong claims using passive stimulation paradigms as shown here. And this is why we went further and with Mélanie Boly from our lab tried to find an alternative to what we do at the bedside, which is looking for command following, but there we are, as we've seen, sometimes biased by that motor responsiveness. So when we're at the bedside asking patients, squeeze my hand, and we see a response, we take it as a proof that the patient is conscious. When we don't see it, we will repeatedly ask the question, and when we don't see the answer, conclude the patient is not aware of the environment, is unconscious. However, we know sometimes there may be a problem. Maybe the patient is deaf, so we will write down, squeeze my hand. Maybe the patient wants to squeeze your hand, and the command leaves his gray matter, so to speak, but never arrives in the muscles because there may be a problem on the way, a nerve injury, spinal cord injury. And we know that in these coma patients, there's always not just the cognitive impairment, but also the motor impairment and very important spasticity. So we tried here to show proof of command following and hence of consciousness without depending on any muscle response directly by looking what's happening in the brain. And we ask a number of things, and these are strange things, like imagine playing tennis, or imagine your mother's face, or imagine singing a song in your head, or imagine walking around in your house. And what you see here is when we do that in healthy volunteers, we can show that, for example, imagine playing tennis will activate your premotor cortex. And it will do so in such a way that we can pick it up, we can read it with the scanner with 100% accuracy. And here you see when you did the spatial navigation, walking around in your house, task activation in the hippocampus, which we know is important for this task, again, in each and every volunteer we studied. So with this tool, we could now look at those patients at the bedside we considered vegetative, but maybe showed some signs of command following. And this was what we published in Science in 2006 now. A patient, young woman, survived a traumatic brain injury, evolved to what we clinically thought was a vegetative state, yet when we asked her to play tennis in her head, you see supplementary motor area activation as in controls. When we asked her to imagine herself walking around in her house, you see parahippocampal area activation as we see in healthy volunteers. In other words, these patients, despite the fact that at the bedside she looked unconscious, could do this task, showed command following as identified by fMRI, and hence was conscious. And actually, a couple of months later recovered. We could also show, this is work by Andrea Soudou from our lab, together with the Cambridge group with whom we developed this paradigm, that this is not just an automatic response of the brain. This really depends on volition. If you see this, it is very difficult, in my view, impossible to explain it in the absence of conscious awareness. And one of the reasons is that the activity is very long in time and has never been recorded in conditions like priming, for example, where there is no consciousness. With the Cambridge group, we could actually push it even further and use this as a communication tool. So when we had the first case, we didn't know if this was 1 in 100 or 1 in a million case report. We now know, having studied in both centers a number of patients, that it is exceptional, but it does exist. Here you see 4 patients, clinical diagnosed vegetative state, showing activity as picked up by the fMRI, proving the patients were conscious. So imagine walking around, hippocampal activity, imagine playing tennis, supplementary area activity. And in one of these patients, we could use this now to try and communicate with the patient. And this is shown here. We started, of course, to validate the technique with very, very simple questions. Is your father's name Alexander? To say yes, the patient had to imagine playing tennis. To say no, he had to imagine doing the spatial navigation task. So very difficult instructions, yet, as you can see, healthy volunteers, of course, can all do this, but also this patient, clinically it was impossible at the bedside to establish any form of communication, and you see that only the fMRI permitted us to have answers to a series of yes-no questions, and I think you can all read here what the answer is. We see activity here in supplementary motor area, and this means a yes. He's answering no, no, yes, no, and this final question, no answer, we don't know. So this case illustrates the power of modern technology to now use this as a means to communicate with patients, where if we depend solely on muscle activity, it is simply impossible. We can actually go much further, and this is work by Bettina Sorger, who's now doing a postdoc in our lab, offering not just a 2-way, but a 4-option choice, and this is currently, again, being validated in coma survivors. Of course, that technology is very, very expensive and is very, very difficult to do in these patients, because when they move, the images get blurred and we cannot say anything. So this is why we need to find for alternatives. And this is actually a European project called Decoder, where a number of European centers are trying to use what is called EEG-based brain-computer interfaces to use this new technology to actually enter into communication with some exceptional patients with disorders of consciousness. Already we see how this technology is being translated to the real world, to the clinical reality. This was a patient I saw, young woman with clinically a state of coma. She survived extensive midbrain lesion after basilar artery thrombosis. Still, 40 days after the acute brain insult, no single sign of consciousness at the bedside. It was only the EEG that permitted us to say she actually was in a pseudo-coma or in a complete locked-in syndrome. What is complete locked-in syndrome? That's those patients with multifocal lesions where even the eye-coded communication is impossible. We used an event-related potential paradigm, presenting a number of names, and again showed command following. This time the command was count the number of times you hear this target name, and then you see again appearing this so-called P3 response. It's very clear when she had to count the number of times she heard her own name. We could repeatedly do this, and these are real data from one assessment showing this patient, despite the fact that clinically she was lacking any behavioral sign of consciousness, she was in a full pseudo-coma, total locked-in syndrome. The EEG-based brain-computer interface was the only way to show she's conscious. We continued treatment, and now she has recovered some motor activity. I will not go into the big problem of language disorders and aphasia, because all we've been discussing so far depends on patients' understanding of language. When we have aphasia, and we do have dysfunction in the language network in many of these patients surviving their acute brain insult, things really get very complicated, as we've recently reviewed with Steve Mejerus in this article. We will now move on, after having discussed the diagnostic problems, the challenge we have to predict what patients will recover. And again, I think that functional neuroimaging, and especially MRI technology, is really offering us with a unique tool by combining what you see here, which is diffusion tensor imaging, which is looking at the brain's connections, white matter tracts. Actually, the blue tracts are showing you mainly here the pyramidal tract going from up and down. The green tracts are connecting the front and the back of the brain, and as you can see here, red corpus callosum, the interhemispheric tracts in a healthy volunteer. By combining this information from diffusion tensor imaging with what is called MRI spectroscopy, looking at the brain's metabolites, we can disentangle, you see here Glasgow outcome scores, those patients who will and will not recover in multidimensional space. And those studies are currently ongoing and look very, very promising in the battery of tests we have to identify those patients who, after their coma, will or will not recover. Functional MRI, in addition to diffusion tensor imaging and spectroscopy, again, can herald some prognostic information. This is two studies we did in collaboration with the Chinese group, where we again looked at the brain's response to the own name. You see here that some exceptional patients will show higher order activation to that autoreferential stimulus. We could even, in a paper that just came out, correlate the intensity of that activation in here, those midline anterior cingulate cortex areas, with their consciousness levels. And interestingly, it turns out, but these are still very limited patient series, that those exceptional patients with atypical high-level cortical activation, classically some months after the fMRI study, will show also clinical recovery. This is what, with HiBo-D from Hangzhou, we could show, doing a review of all published cases. You see it's not many, only 45 patients, and that's a paper from 2008, where when you have that atypical higher level activation, chances are high you will recover consciousness. And in contrast, when you have only that low level primary cortical activation, chances are high you will fail to subsequently recover consciousness. Again, moving from MRI to electrophysiological measurements, I think the electroencephalography recording is a very rich but complex and informative signal, which we here try to reduce to one value, which is called the bispectral index, ranging from 0, isoelectrical, to 100, full awareness. Actually, it is validated in general anesthesia, and it is the only FDA-approved consciousness meter. We showed it also works not only in sleep, but also after coma, and you can here see the correlation on the abscess with coma recovery scale total scores and this bispectral index. You see there's a statistical correlation for the group, but still too many false positives and false negatives to be useful in individual cases. And again, statistically, we see that the higher the value of this bispectral index, the higher the chances are patients will subsequently show a good outcome, as published now 2 years ago by Caroline Schneckers. This brings us to the final section about treatment, where we can rather be brief, because in terms of curative treatment, evidence-based treatment in those patients with disorders of consciousness, I think we really at this moment have a problem. So I will start by discussing symptomatic treatment in these patients, and I think the most important is looking at pain. We did with Atina Demerzi from our group a survey of over 1,000 healthcare givers, asking them the questions: do you think patients in a vegetative state feel pain? And as you can see, the results are question is very controversial. About 56% of medical doctors think, yes, these patients can feel pain. Significantly more, 68% of the nurses thought they felt pain. And interestingly, the variable that predicted healthcare givers' responses was their religious beliefs. People in this European survey, mostly Christian healthcare givers, were significantly more tended to say, yes, there is residual pain perception. So, well, I think we should have evidence, and it should not depend whether you're in a hospital in Rome or wherever else on the planet, whether or not you're going to receive painkillers in this condition. Actually, it is very difficult. If you decide even to give analgesia in these patients, classically what you do is you start with very low level aspirin, paracetamol, and then increase up to morphine and its derivatives, up to the point where the patient tells you, I do no longer feel pain. But these patients, by definition, cannot give you that answer. So we developed a scale, which was the first to quantify possible pain perception. We called it the nociception coma scale. It just came out in the journal Pain, looking at motor, verbal, visual, and facial responses to a standardized noxious stimulation, and proposed that when these 4 items with every maximum score of 3 are total score above 7, we should start analgesia. And this permits us not only to assess the patients in a standardized way, but also to communicate our findings between healthcare givers and to follow up the effect of our analgesic treatment. Now, saying something meaningful about pain is very difficult. Pain, like consciousness, is a subjective first-person experience. So, again, functional neuroimaging is of major help here. And we use this technique in healthy controls, look at the brain areas that activate when we apply noxious stimulation, electric stimuli at the wrist. You see it's not one region in the brain, it's the pain matrix. You see on these transparent glass brains here, starting with the extreme looking what's happening in brain death. Things are very clear. There is no neuronal activation whatsoever in patients with the clinical diagnosis of brain death, whereas in the vegetative state, we not only have subcortical brainstem and thalamus activity, but also here in the gray matter, and this is the primary somatosensory cortex. However, looking at functional connectivity, functional integration of the brain to these stimuli, we could show that this was like an island, disconnected from all these areas you see in blue, and you will recognize the rest of the pain matrix and that so-called frontoparietal workspace, which is critical for conscious perception of the external stimuli. And this was in sharp contrast to what we saw with patients who were not vegetative but in a minimally conscious state, where brain scans showed the full pain matrix activating, so also secondary somatosensory cortex and insula, and here, importantly, the anterior cingulate cortex, which we know is important for the affective, emotional perception of pain. In other words, given that minimally conscious state patients where at the bedside the response to pain is very comparable to the vegetative state, despite the fact they cannot tell us they feel pain, given this full activation of the pain matrix using functional imaging, we should, I think, systematically give them painkillers. Very quickly about the curative treatment, as we said, no evidence-based treatment in favor or disproving the efficacy. I think functional neuroimaging again can be useful on smart cohort studies. Actually, a retrospective study showed that amantadine was correlating with good outcome. So we looked at its effect on brain function. You see here in yellow and orange the brain's metabolism increasing using baseline drug, washout drug, ABAB design, drug-dependent activation of frontoparietal network, which I think is interesting also for the pharmaceutical industry when looking for new drugs in terms of brain plasticity. I will not come back to what we already said about deep brain stimulation in minimally conscious state patients and conclude with some ethical issues. Evidently, all that has been reviewed so far is scientific research that needs to be performed in a well-defined ethical framework, which actually, together with Joe Frins from Cornell and the Stanford and Columbia group, was defined in this review. You can read in the American Journal of Bioethics. I just want to say some words about the quality of life, which is a very difficult question to give meaningful answers about what is it like to be minimally conscious. But in locked-in syndrome patients, we can try to answer that questions and ask patients themselves. Here you see results, a collaboration with the French Association for Locked-in Syndrome using the short form 36. All patients with locked-in syndrome, of course, scored 0 on physical functioning, but you see their self-scored general health and mental health is not that much lower as compared to the healthy control population in France. And here a recent study we did with Dorothée Lullet showing that we tend as physicians and even as family members to underestimate quality of life of these patients. I will not go into the issue of euthanasia, which exists, but it's rather the exception than the rule in locked-in syndrome patients, and conclude. I hope I've convinced you that in terms of the neural correlates of human conscious awareness, this can be seen as an emergent property of the collective behavior of that frontoparietal neuronal global workspace we see here colored in purple, and its cortical and thalamocortical functional connectivity. We've also seen that within this network, the lateral areas, dorsolateral prefrontal, temporoparietal, seem critical for external awareness, whereas here, mesiofrontal, anterior cingulate, and posterior cingulate adjacent precuneus, those midline structures, seem critical for internal, or if you wish, self-awareness. We've seen that it can be very challenging to identify bedside signs of consciousness with diagnostic error up to 40%, pointing to the important role of functional neuroimaging and complementary testing, which also will be useful, as we've seen, in terms of predicting outcome or the prognostic use of functional MRI and novel MRI technology. And current multicentric studies are actually aiming to identify that value. Finally, in terms of patients' treatment, we have seen again that functional neuroimaging gives us information in terms of emotional processing and residual pain perception in minimally conscious state patients. And we also seen that there are new therapeutic options, one example being thalamic deep brain stimulation. Evidently, problems in terms of diagnosis, prognosis, and treatment have all their specific ethical consequences. I think, however, it is a very challenging time because those disorders of consciousness, vegetative, minimally conscious, clinically defined, are now being challenged by new technology. For example, the boundary between vegetative and minimally conscious, which is the emergence of non-reflex movements, signing awareness, are now, in some patients, being challenged by event-related potential or functional MRI technology, revealing subclinical signs of command following. And similarly here, the upper boundary of the minimally conscious state, defined by the emergence of functional communication, is again being challenged by EEG, brain-computer interfaces, or real-time fMRI technology, enabling scientists communication independent of patients' motor pathways. So I would just like to thank the many people who did the job, and of course this is part of collaborations with many centers, Cambridge, New York, and all the centers listed here. I would like to really thank you for your attention.